Hi, in this video from SuVi Eye Hospital, Kota, Rajasthan, we describe the management of traumatic cataracts and the various aspects in traumatic cataracts like irido-lenticular adhesions, posterior capsular plaques, small fibrotic pupils and calcified capsules, etc. Now, this is a case of a traumatic cataract which has a fairly fibrotic membranous cataract, irido-lenticular synechiae. The pupil is bound down to the capsule and the cataract is white in color. So we have to be well prepared and carefully plan these surgeries, and as we may have to deal with a variety of problems in these cases. This is an irregular pupil, and because it had not dilated, we first inject intracameral preservative-free lignocaine into the anterior chamber, and under an air bubble or with the soft shell technique, we stain the anterior capsule. It is also a good idea to use Viscoat or Z-hyaline, etc., which can protect the corneal endothelium well in the case of additional maneuvers needed in these surgeries. After capsular staining, we use a dry stale or a Visalon cannula or an iris hook or some such instrument to reduce the irido-lenticular synechiae, and we can then use a Kruglen 2-hook technique to stretch the pupil and enlarge the pupil. The pupillary stretch technique is sometimes not favored because of the fact that it may release prostaglandins from the iris, which may further cause pupillary constriction during the surgery. However, in these traumatic cases, in some selected cases, it can give very good results and give a fairly adequately sized pupil. Once we have an adequate sized pupil, we perform capsulorhexis, which again has to be very careful because the capsule may be fibrotic and adherent to the iris. And this capsulorhexis may have to be performed exactly at the pupillary margin in cases of not so big or enlarged pupils. Once we have an adequately sized pupil and a good capsulorhexis, the rest of the surgery is not particularly difficult as compared to other surgeries. Some of these cataracts may be partially absorbed, and the posterior capsule may also have pre-existent defects. Therefore, we need to be careful while performing the surgery and be specially gentle towards the posterior capsule. Nuclear rotation again needs to be careful, especially when a posterior capsule tear or dehiscence is suspected, and the movements should be gentle as compared to any routine case. Now we can see that there are some membranous bits which are lying under the iris, and they may be very tenacious to remove. We perform an irrigation aspiration, and suddenly we are faced with this capsule plaque that has fortunately come out easily without much manipulation. Otherwise, these capsular plaques on the anterior or posterior capsule are usually very tenacious and extremely difficult to remove. The plaque sometimes comes off with good visco dissection and irrigation aspiration, but it may even have to do a posterior capsular exit. We implanted a standard hydrophobic acrylic IOL in this case. And the IOL was carefully dialed into the bag. Some of these traumatic cases may have compromised capsular bags or compromised zonules, and then the surgical technique needs to be varied accordingly. Because there is increased trauma in these cases with manipulation of the iris, we must do a good AC wash at the end of the surgery and remove any debris that there may be present in the anterior chamber. We also sometimes use intracameral preservative-free triamcinolone to provide some post-operative anti-inflammatory effects in these operated cases, and also in those cases where we need to see whether there are any vitreous strands to stain the vitreous fibers. So to summarize, traumatic cataracts can pose special challenges in management as they have small irregular pupils with irido-lenticular and irido-capsular adhesions. The lens may be calcified, there may be capsular plaques which all need to be tackled, but a careful planning and being prepared for any eventuality makes possible to give good results in these cases too.